Thank you so much, Mario, and thanks everybody. It's a pleasure to get to talk to people. I've been in New Mexico about 12 years, and very soon after my arrival, I began to get involved in the concern of substance use and treatment of substance use disorder. Ironically enough, I came to UNM from UCLA, and ironically enough, people have been trying to get me involved in various projects to do with substance use disorder at UCLA. And I said, no, there are lots of people involved in that there. I'm much more interested in community health and the underserved, which I had been focusing on at UCLA. But when I came to New Mexico, first of all, it was mandated that everyone on the faculty at UNM in family medicine get the X waiver, but not very many of us were actually diving in. And I was at a clinic where it historically had a high prevalence of substance use problems in Albuquerque, and I thought, well, somebody got to just start doing this. And so really with the help of a wonderful psychologist in the clinic, we just sort of started up our own MAP program for opiate use disorder and Suboxone. And then gradually it sort of became, as this same population was one which I continued to work with, as certainly the disadvantaged and population is one that I've spent my entire medical career working with. It became an increasingly large part of my work, and eventually I went ahead and got the board by the alternate pathway for family physicians in addiction medicine. So that's pretty much what happened here. Let's see. Oops, well, we're out of order. I'll go back. I just want to say that I got in my email inbox this morning. I just happened to note that it turns out that this week is National Addiction Treatment Week, and if not for being a member of the American Society of Addiction Medicine, it probably would have blipped right by me. But I will say that you're welcome to follow these links if you look for www.treataddiction-savelives.org or go to the ASAM site. You will see that they have some very interesting online activities, and they have information on the 8-hour course for pain management and substance, which is freely available, and some other resources which I think are great. So as I say, I wouldn't have known, but fortuitous timing, Mario, that got me to do it. It turns out during National Addiction Treatment. Okay, so this first slide is the context that I think we all know, but it's worth. I mean, I think the graphic is if I dare use the word, sobering, and what we know about the experience under COVID. So this is the figure of national drug-involved overdose deaths for all ages, 1999 to 2021. And all you have to do is look at what the trend is, look where it's going. And, it's harder to read on my little screen, but I think you guys can probably see that the really precipitous rise there is deaths by synthetic opioids other than methadone. So that's fentanyl. So we're talking about fentanyl, and everything else. Also, if it were not for fentanyl, those would be plenty impressive spikes on their own. So for stimulants, cocaine, prescription opiates, benzodiazepines, heroin, antidepressants. So I mean, this is where we are now, and why this is presumably of concern, I hope, to everybody in the audience, the trainees. Some of you may be, I'm afraid I can't see everybody in here, but some of you may well be working in the field. So this is our context. As I was preparing, I also came across another rather disturbing picture of what it is we're going through. Let me see here. But just starting with some epidemiology and for context, and then we'll be talking along the way principally about alcohol use disorder, opiate use disorder, and a little bit of a sidebar on the coming scourge of xylazine. But in any event, so as I was looking through the materials on burden of death and use disorder by region, I saw this for the Americas. And once again, really just the visual bars tell a whole lot of the story. If you look at us, we are way, way, way beyond everybody else in terms of the population rate burden of deaths. I mean, I don't think I'd even registered that we were, 10 times, everybody in the Americas, and 3 times even are the people that we like to compare ourselves, the Canadians. So, who are plenty live to their own problems in this domain. So I think that again, and given that this is, to Addiction Treatment Week, it should remind us of the ways in which in the US we have serious problems which are really unacceptably large in dwarf many other countries. Then again, looking a closer look at the United States, and of course, I think again, any fairly well-informed citizen and citizen of the medical world knows that New Mexico, unfortunately, has always generally shows up in all of the measures for both disadvantage and socially and medical problems, particularly related to socioeconomic status and poverty, frankly. So New Mexico was always near the top. So this is the distribution of drug-related U.S. deaths in 2021. And here we see New Mexico light blue, which actually is progress, because the states which are worst off here are the ones in green. And so New Mexico has moved down. Fortunately, I think, this is real, is that we've made some progress in New Mexico. We're still well up there, but we're not in the top 1 to 2 to 5 in terms of all-cause substance-related deaths, but still very concerning, and still in the second tier. So the other thing which I think this is something that I've been thinking a lot about in my current project, which if we have time at the end, I'll talk about, which is the Partners for Recovery, and I won't interrupt to say too much about it, but it has to do with trying to understand and extend care for substance use disorder across New Mexico, being live to the very particular kinds of problems that we have in our state. This slide shows the burden of substance use disorder in the US in rural versus urban settings. And it turns out, and so, one of the things you may have heard in the news, and we think about many documentaries and some, sort of docudramas about West Virginia and some of the sort of mountain poor states on the East Coast, but we've heard a lot about rurality. So we know that in addition to low SES, and one of the associations for a disproportionate burden of substance use disorder problems and therefore also deaths is rural states. But it turns out it's a little bit trickier than that, because when you look at this, it turns out that within rural states, there's actually, there's a split between and that is primarily rural states. So like New Mexico, which has, a large urban population, but also a very large rural population. It turns out that the splits are not straightforward. So there are states which are rural but have an urban rate of death and drug overdose death that's higher than the rural portion. And that seemed like a really interesting finding to get one's head around. Mexico falls into that group. We have the Northeast states, which are essentially all urban, so we get nothing out of that. And then we have a few states which have a rural rate higher than the urban rate. But New Mexico falls into this largest group, which is largely rural states, but where the urban deaths per population actually outweigh those of rural regions. And I haven't really, I have to say personally, I haven't finished thinking about this, and I'm not sure that it doesn't require a lot more study to really get one's head around. But as near as I can make out, having worked in this field, and now after leaving UNM, I worked at federally qualified centers and a couple in rather remoter parts of the state, realizing that there is this dynamic between folks in rural and urban areas, and there's the kind of magnet of the urban areas in the underserved rural settings, because we know that, among other things, one of the things that we mean by low SES is that people often don't have jobs and they get drawn to urban areas from rural areas. There's the huge pull which happens in rural states towards urban areas. And so if you come from the rural areas to the city with already suffering disadvantage, so maybe not having finished high school, maybe with having gotten into a little bit of trouble, maybe not having good prospects for jobs, having left your social support structure at home in a more rural county, you're then stuck for all of the important risks and setting, which becomes important to say, well, okay, that's a way perhaps of explaining this finding, but also says something about the real experience that I think many of us know. Some of you may know through families, I know through my work in different parts of the state, that there's a huge problem when we're actually trying to help folks in terms of where their support structure is. So that if people have substance use problems, or they may have behavioral health problems and get admitted for something in Albuquerque or ending up in Las Vegas, something like that, once they're discharged, they're out on the street in an urban setting where they do not have a support structure. So that turns out to be, I think, a very an essential feature of what looks like a sort of saying, well, okay, yeah, so cities and in rural states a problem, but something that in terms of our management and helping people, we have to think about, where do they come from? Where do they live? Where is their support? Certainly with the Native American folks, if they end up, and we know that just terrible things happen even in just smaller towns and that are concentrations in some of these settings. And certainly when many of the people of lower advantage come to places like Albuquerque, then we often see disastrous consequences. Okay, so actually I talked about that in the picture, but this is essentially the content slide and saying a little bit about these same things, and that this parses out a little bit differently, both over ethnicity and gender. And as I say, I don't know what yet to make of it, but I'm sure that some of you may be able to even give some thought about it or have experiences which actually could provide even a better story. Okay, so now coming to treatment proper. What we saw from the scary COVID slide, we know, I think we have a special consciousness for opiate use disorder in New Mexico, probably dating back because of now bygone era. I have to say in the last 5 years, since heroin seems to be all but disappearing. Sorry, someone's got a message. Somebody is okay. That heroin seems to be all but disappearing, but remember that New Mexico, I think, still has the consciousness of having been somewhat tragically labeled as, and part of Mexico, as the black tar heroin capital of the world. So we think about that. But one of the messages from the other slide and some other things that we'll see is that really by numbers, I think the other drug that we can say has been a disproportionate and tragic burden in Mexico is alcohol. Because if you look at it, so we can see that this is for 2021 again, that for actual deaths associated with alcohol use disorder are nearly twice the number of overdose deaths, but that we see that in terms of both misuse and use and disorder, that the numbers are perhaps, the burden of illness is perhaps 5 times as high. Now, the fact that when we do the comparison in terms of overdose deaths is one of the other reasons that we have, I think, such a highly attuned consciousness of opiate use disorder, because the death rate is very high. That is, we know this from the nature of what people are doing, is that they're walking a tightrope. We say, well, in terms of chronic and slow death, alcohol, more than probably the annual deaths associated, is probably underestimated because it has impact on other conditions and often things which don't show up on death certificates, in fact, that may actually be linked directly to alcohol use disorder. But still, we see that while there are 5 times as many diagnoses of the disorder for alcohol over opioid use disorder, that the number in terms of deaths is, has the opioid deaths are more than half. So the message is, okay, in terms of numbers, and perhaps as a society, it's at our peril that we in any way underestimate alcohol or lose sight of it. On the other hand, the opiates are scary because they're killing at even higher rates in the disorder. They're killing younger people, and they kill suddenly. So that's a message there. Okay, so this is just another visualization of the numbers here when we talk about all-cause mortality. And as I say, alcohol use is probably figuring into some of those things that it's not even being calculated there, because we know it's actually involved in heart disease risk, it's involved in cancer risk, chronic poor health or self-neglect, higher risks of death in COVID, the folks living out in camps and not having taken care of themselves for many years, much higher risk. So all those things you can say, well, alcohol is actually probably more implicated. But on this particular graphic, the substance use disorder isn't even registering as a number. So it's not in the top tier. So again, just another reminder of thinking about proportion of problems. Okay, so now coming to particularly thinking about the family medicine trainees who might be in the audience, we do now have explicit recommendations from the U.S. Preventive Services Task Force for screening everybody, screening all adults. And this was in 2018. The Preventive Services Task Force explicitly gave the directive that we should be screening all adults for alcohol use disorder. At the time, they also investigated adolescents, but decided that there was insufficient evidence to make the actual recommendation. Now, I hope, and this could be a theme for discussion, or you may take it back and discuss among yourselves in your residency programs. I hope that folks will then say, wait a second, this is a place where evidence and policy diverge slightly, and there's kind of a little bit of a running theme in my talk, and because I'll have more to say about that along the way. But say, who do you think becomes adults? It's adolescents. Nobody says, well, we were here in school, cutting school a little bit, getting into a little bit of trouble, coming from a place where school hardly keeps my attention all day at all. But you don't need to talk to me about any of this stuff until I'm 18. Now, the pediatricians, after COVID in particular, have already gone ahead and had the sense to see that they need to start screening adolescents for behavioral health and mood disorders because they're so stressed and depressed, and saying, well, what's the highest association for substance use and self-medication getting into these troubles is, if anything, is those things. It said, well, that makes no sense. So I would just submit as saying, look, if we are going to be talking, if we're going to be doing the screening for depression among children, and then also for some of the other burdens of disadvantage and low SES in littler kids, or things like obesity and cholesterol disorders, risk for chronic illness, we certainly could be talking to adolescents about these things. And we should not wait around until the USPSTF finds sufficient evidence to convince us. So I would just say, yeah, it certainly, there's nothing to stop you from doing it. And you can't say, well, that's not evidence-based. This is exactly the problem. Sometimes getting the evidence to say what we all know to be the case is the problem, and not saying, oh, well, you were irresponsible. So I just would like to flag that to folks. Okay. I won't spend too much time on this. We get lost in this, but here are a couple of they do recommend a couple of the screening instruments. There's the audit C, which is 3 questions and toting that up, but they found as effective is the single question, which is the National Institute of Alcohol Abuse, which is, how many times in the past year have you had 5 drinks for men or 4 drinks for women in a day? And a response of 1 or more warrants a follow-up. Okay, so if anybody, because of binge drinking and also because of the proportion of what's considered an acceptable and reasonably healthy or acceptable amount of alcohol to consume by normal standards, and that the 1 question is also really nice because obviously as practicing clinician physicians, we all just feel overburdened with what we have to do in any given visit, but this is really short and also doesn't register as sort of saying, well, I sort of thought you were having a problem, so here's this little survey to do, and so it has appeals from many angles of that kind. Okay, so now, as primary care physicians, we have surveyed people and found out a whole lot in our practice that actually need pharmacotherapies, or in addition to counseling and all of the other modalities that might be available to us, the recommendations are for actually doing these things. So what are the sorts of, what are the medications which are, again, by evidence, have received official blessing, and what are the sorts of things which are put into question? Okay. So, and this is from the 2018 American Psychiatric Association guidelines. So naltrexone or acamprosate, which you may know by Camprel, are good, safe medications for reducing the use of alcohol without requiring cessation on the individual. So a really great thing to be able to offer people, because they say, look, yeah, we want you to be working on cutting down. Let's do all this counseling, therapy, and cognitive behavioral, all the various kinds of helpful human to human interaction that can help. But you don't have to quit. Now, this has always been another head scratcher to me, why it's even still out there at all. But disulfiram antabuse, which I'm not sure even folks are too familiar with these days, because it's so much fallen into disuse, but it's still approved. Now, I have never seen the role for this, but apparently, the studies say, evidence shows that it can help some people. That people who are interested in doing this as the kind of people who said, no, I need an insurance policy. The way in which, as we come to opiate use disorder, a small number of people will prefer naltrexone or Vivitrol because they say, no, I need to know something that will, really, doesn't let me off the leash. And, but I have to say, if you're not familiar with it, what disulfiram does is just makes you sick if you drink. And I have to say, I have never understood that as a kind of response, because I can think that if you did it, you would only do it once or twice and then stop the medication. So it's not going to help anybody in the long run. Okay, but a couple of other agents, the anticonvulsant Topamax or topiramate and gabapentin, are both very safe and have some long-term benefit. And as we'll talk a little bit about gabapentin down the road, has a lot of appeal because it is so safe and because it also has anticonvulsant properties. And of course, seizures secondary to alcohol use, either excess of use or withdrawal, are both enormous considerations. Okay, so the APA recommendations also explicitly said some things they didn't want us to do. So they, surprisingly, in the first entry there is antidepressants. So you'd say, well, the antidepressant should only be used where they are being applied to a specific co-occurring disorder, which is separately diagnosed. So maybe that's what comes from psychiatrists. But again, one of the things that I think all of us probably either know from individual experience or through practice is that the two are almost inseparable. There isn't anybody, almost by definition, you say, well, to the psychiatrist, gee, do you guys read your own diagnostic and statistical manual? Because in order for something to be a disorder, by the very first definitions, interestingly, they set up very pragmatic kind of definitions, it has to cause dysphoria, it has to cause adjustment disorder, it has to cause upset. So anybody, and in addition, we know that people are self-medicating, who are drinking, or that all of the, by the time it's a problem in drinking, you're depressed and anxious because it's affecting the rest of your life. So it strikes me as a little bit underplayed here, and we'll have something to say about what the caution is and why they would lump it over here, as opposed to saying, no, it's perfectly appropriate. Here are some cautions. Okay, benzodiazepines, right? Well, basically, not any quarrel here. Benzodiazepines are an absolutely, if not essential, first-line treatment for acute alcohol withdrawal, but have almost no role anyplace else, unfortunately. So certainly not in people who have a propensity for mood adjustment by medication. Okay. And then there's some warnings about secondary effects of a couple of things for acamprosate. Naltrexone, surprisingly, and I'll have a little bit more to say about this, it is on there because of a worry about alcohol use and the effect on the liver, so in acute hepatitis or hepatic failure. However, there's really very little evidence that naltrexone is itself hepato or liver toxic. It's one of these things where it's a little bit like like the package inserts to medication say, well, has anybody's liver ever been injured by naltrexone? Yes, there are cases. But in fact, it has, and the other problem is the liver being the liver is involved of metabolism of not all, but the vast preponderance of everything that we put into our bodies. The liver is just this industrial waste facility, and sees almost every kind of chemical, certainly all the complex ones, get addressed by the liver. So the fact that the liver might be involved is certainly there, but in fact, in all but really severe liver failure, it should not be considered a problem. So that's something that, now, okay. Antidepressants. So here's a quiz. Do we have, I'm afraid I can't see the whole gallery. I don't know whether I don't see any specific residents here. I was kind of hoping to address this to residents, but here's a little quiz. Antidepressants in the setting of alcohol use disorder are contraindicated. I've kind of answered is a little bit of a slam dunk here, but antidepressants in the setting of alcohol use disorder are contraindicated for hepatotoxicity, contraindicated for risk of bleeding, of no clinical benefit, or an excellent adjunct to therapy in appropriate cases. If anybody wants to, you can either speak up or put an answer in the chat. No, don't see any takers. Four, yes, good. Oh, excellent. Kristen Drake, a brave soul, said, okay, good. Let me make sure I didn't hit twice, did I? No, okay, yes. Yeah, so of course, because as I was just saying, no, of course, I mean, anybody who has worked in a primary care setting, yes, I mean, you're going to see those people. So the question is not whether or not they should have antidepressants, is how to choose one. Can they be implicated in hepatotoxicity? Yes. Is there an issue of bleeding? Yes, indeed. There are particularly the SSRIs are associated with increased risk of bleed. So if somebody has a GI bleed, we shouldn't be choosing those things. And we know, well, of course, too easy to say they're not of clinical benefit. And yes, in appropriate cases. Okay, oops, come on. This one. Okay, so here's what can we offer. Okay, so SSRIs are considered relatively to absolutely contraindicated for their bleeding, for their increased bleeding risk. But so if we're going to choose one, there are a couple which are high on the list. Mirtazapine and bupropion are both not, in fact, it's not exactly certain the mechanism of their action, but they are not known particularly for hepatotoxicity. They're not involved in bleeding risk. They don't have the serotonin effect on the gut, which is thought to be involved in increasing GI bleed risk. Bupropion, which is also known as Wellbutrin, and was then packaged and marketed for a while, though I don't know I'm not even sure whether it's commercially available now, but as Zyban for smoking cessation, actually has interest as an adjunctive medication for non-specific treatment of substance use disorder. So great choice, as long as people don't have high blood pressure. You probably would see on the black box warning for it, seizure disorder, say, oh my gosh, they're drinking, are they at risk for seizures? Well, yeah, but not when they're drinking and not if they're not withdrawing. If they don't have seizure disorder, you're probably okay with it. Gabapentin, excellent choice for anxiety. As I was saying a little bit before, there's even regimens for alcohol withdrawal that we'll talk about in a minute. Topamax, again, another mood stabilizer, adjunct to antidepressant treatment, and relatively safe in the setting of injury to the liver. Okay, I tend to, I guess I run off at the mouth and I tend to run ahead of my slides, but this is just to say, here's a little bit of documentation for anybody who wanted to follow it up liver toxicity in naltrexone. This is from a very reputable from Liver Tox site, which is a great resource if you're not familiar with it, saying, well, basically summarizes the evidence, and you can find this and say, there's actually no real strong evidence that naltrexone is specifically been found to be the causative agent by itself in liver injury. Has it been around when it happened or made something? But yes, it probably can be. But there's almost no reason even to say that. So again, the there's I don't know. Maybe I'm just getting to be, or no, that's not fair. I was always a curmudgeon. But I'd say that one of the things that I think we forget, and I want to say this to the trainees in particular, and it may be as medical information and informatics and AI now evolve, there's this feeling like, well, in medicine, there is a right answer. And it's your job as the provider to always try to hit that, best evidence-based answer. But, there's evidence and there's evidence, and often the evidence on which decisions are based is not all evidence is created equal. And I would really encourage everyone in the medical field not to forget to use your brain. Because the expert panels have ground through everything, and these things are made, these, if they were still smoking, these would be smoke-filled rooms. People are saying, well, I see it this way and that way, but then something comes out, it's ex cathedra, and they say this is the way it was, and it is, and actually it's a whole lot more gray area. So it's really important that we be able to think through and distinguish, and then sort of ferret it out when you need to. And that you are yourselves the expert that gets to decide based on evidence. It's not somebody said, digest it and just spat it out to you and say, oh, there you go. Okay. So that I hope is something that people would take away from almost any conversation with me personally on medical information and decision making. Okay. So here's so now getting to the hard part of, or not, maybe, maybe hard's not the right word, but maybe slightly more daunting or scarier part of treating alcohol use disorder is withdrawal. So, which can be done in the outpatient setting. So just to say that even though we think of alcohol withdrawal as one of the really dangerous withdrawal syndromes, one of the really dangerous scenarios in all of substance use disorder, it can be treated successfully in the outpatient setting. And particularly when you know that for the outpatient purposes, that people have a relatively intact social structure. So now that unfortunately doesn't apply to a lot of our folks, where we wouldn't send someone back to one of the informal camps where a lot of folks unfortunately have to stay with medications for alcohol withdrawal, particularly if it involve benzodiazepines, but that you can safely do this, okay? And here's the other thing, is that one of the reasons that we can do this is that while most of the time when we talk about protocols for alcohol use disorder and treatment of withdrawal, is that they're treated to the scales, particularly the CWAS scale, but there's some others, but that doesn't need to be the case, and we'll find out why in a minute. And here's my slogan, is that treat the patient, not the scale. Okay, so if we say we're going to give someone a program for withdrawing from alcohol, you can safely do this through instruction, as long as you feel confident the person can follow the program by themselves. Okay. And that surprisingly, the experience that we had at the Santa Fe Recovery Center was that it was even possible to treat this without scales and in a way that was actually addressed the experience of the patient. That was a little bit better. Okay, so what's the idea here? Most of the protocols look at CWAS scales and they wait for people in outpatient setting of examples of alcohol. Is that, we got duplicated. Okay, sorry. That most of them have people essentially all but go into withdrawal. If you look at the protocols for treating alcohol withdrawal, people have to get sicker and sicker before you start treating them either with a benzodiazepine. The one which I tended to favor was Librium chlordiazepoxide. Valium's also used the longer acting ones because they get more of the benefit over time and don't have to be dosed as frequently. But essentially what you're doing is you're waiting for people to sweat and tremble and feel really sick before you treat them. Now, the first question that I asked when I came and particularly had lots and lots of experience with this in a much more acute setting, so the Santa Fe Recovery Center with the detox, where people really already were sick, say, well, why are we waiting? Because you're saying, what are we really afraid of? We're afraid of seizures and DTs, which are potentially life-threatening, but why wait around? If I'm saying that the medication which I'm going to give someone if they get sick enough is safe, why don't I just start? I'm saying, why would you wait? Because first of all, you can say, well, I say, well, not everybody will absolutely need it. On the other hand, the downside is massive. When we're talking about alcohol withdrawal, which, as we said, was one of the potentially lethal withdrawal syndromes in the world of substance use treatment, and say, why would you even play around as opposed to giving someone 4 days worth, because the period that we really worry about, of course, for those, the residents, of course, all know this, but is the 4 days. It's 96 hours is where you say, well, you're going to have delirium tremens, you're going to have seizures, they or simply have organ failures, or permanent brain damage. It happens, the vast preponderance will happen in 96 hours. So say, fine, just treat them for 4 days. And we can do this on a taper. It's a safe medication. I'm not giving them benzodiazepines to go out with, in handfuls, and it's in a controlled setting. So either in a setting that where people have a home, they have somebody to watch with them. If they're getting sick, they can be taken to the hospital. But you just start treating. You just wait until a certain amount of time has passed so that you're pretty confident that you're not putting something like benzodiazepines right on top of a lot of alcohol, which can have the consequence of interactions and central nervous system depression. But if you wait a little while, you're fine. And then again, remember, these folks, since they're going to withdraw and they deserve treatment, these are people who have been drinking alcohol for a long time. Their liver is used to seeing combinations of things with alcohol. So the worry is not like you're saying, well, you're putting into someone whose brain and liver is alcohol naive and then putting benzodiazepines on top of it. So turns out that just setting an interval, which we said 12 hours after the last drink to start. And it turns out it was perfectly fine. And people are a lot more comfortable. You don't make them sick. It's safe. And said, again, so why are people using these CWAS scales? I put the link in the previous slide to the scales. Again, the medical folks, the residents will all be familiar with them. So you can look at them if you want, but say, why do we keep subjecting people to these scales and asking how they're doing when we could do this? I said, well, because those things were measurable. We could say, well, if you're think about it, how it comes about. In a research setting, you say, well, I need to have some measure of how sick people are before, it was absolutely essential that we treat them. But that's a question which lends itself to statistical analysis, not, was that just safer for people and did they feel better? Because I said, why should I even countenance that? Because I can treat them right away. And I don't need to wait. Say, I know by history, I know what they told me they've been doing, how long they've been drinking, the quantity they've been drinking, that they are going to need this. It's just, and so setting oneself up again, yeah, evidence says, absolutely. Is this scale validated? Yes. If you get to this score, should you, when you've been waiting to treating to the scale, yes, you should do that. I said, but why didn't you treat them 4 hours ago? No problem if the person didn't absolutely need it. I'm not trying to predict them whether they're going to be the sickest one. And besides which, they'll just feel at worst a little less anxious and maybe a little sedated. And that's it. And then we also, if people are really worried, which, I will say, I have a friendly argument with Dr. Eric Ketchum, whom some of you may actually know, but who is one of the leading lights in emergency medicine and substance use disorder in both the state and the country, who prefers gabapentin. And I say, well, I like Librium because people feel less anxious. Gabapentin is a safe drug, but it's not as good an anxiolytic. It works on some of the same systems. But why not do this? I don't want them to run away from doing this. I want them to feel better. But both are good. Okay. Okay. Now we come around final use disorder. Is probably where the public consciousness is really so focused these days, and a topic that's taken up a lot of my energy as well. And as we were saying before, because of the risk for deaths at early age, sudden death, repeated near misses, why it's so much on our mind. But perhaps it has to be, for me, in the medical world, as disturbing as the problem is, it has a great treatment. And I have to say that in my experience, and as a family medicine physician, you get to see lots of different regions of medical care and work with patients who've been treated for different conditions. Buprenorphine is just one of the best medications ever. I just have to say, so this in Suboxone, and why is that? Okay, so what is buprenorphine? So buprenorphine is the more important component of the combination drug that we know as Suboxone. Okay, and pharmacologically, what is it? Its mechanism of action is as a partial agonist, partial antagonist on the mu opioid receptor. So now we're getting a bit technical. Apologies to people for whom this may be too technical, or those people for whom this is all old hat. But what does that mean? So these are the receptors in the brain which particularly govern the mu opioid receptor. Is one of a number of opioid receptors, but it's the one which is particularly associated with rewards for use of opiates, so the pleasurable and dependent generating receptor. And it's also one which in higher quantities or repeated activation actually causes central nervous system depression, so sedation. Okay, those are two important features. And then for people who have had it chronically stimulated with an agonist, so something like heroin or fentanyl or methadone or pure opioid agonist, which is one which acts positively on the receptor, a chemical which acts positively on the receptor, as opposed to an antagonist which acts negatively on the receptor, in the presence of repeated activations, it actually has an additive effect. So that if you give more heroin, it's not saying, well, all the receptors are filled, but actually if you give a pure positive agonist, you will have continued action on that center until it causes respiratory depression and death. That's how that happens. Okay, so that's what's happening. So buprenorphine, in being this sort of half and half substance has a much safer profile as compared to the pure opiate. So if you compare the case of methadone, which is a pure agonist, it's just actually preventing people from withdrawing. It's just as bad. It's open to abuse. People can do all kinds of things. And it has many, many problems associated with it. There's good evidence for people. Some people really benefit from it, and from that structure is important. But it has all of the side effects, including sedation, including constipation, tolerance, need for higher dose. Those are all true in methadone. Okay. Then there are other alternatives, particularly when we think of opiate antagonists. What we think of is naloxone and naltrexone in particular, but these are things which block the opiate receptors. So, which essentially just reverse it. So they're safe, but what do? They prevent people who use from getting high or having sedation or pain control. But the problem with this is, this is of the pure receptor antagonists, the most well-known being naloxone, which is Narcan. And so hard to convince anybody who has been involved for a long time in the use of a substance for, let's face it, pleasurable effects, to be committing to something which absolutely interfere them or reverse them. It's a hard sell. And for some people who perhaps with the stigma of use, the corrections facilities all say, well, we don't want to give people a replacement, so we'll offer people leaving Vivitrol. I mean, now fortunately there's some programs, and I know in Bernalillo County for actually introducing Suboxone into the corrections facilities in a way that's not the illegal stuff getting in there. But it was popular in corrections nationally to offer people the Vivitrol injection when they left. Nobody would take it. They wouldn't, because they're getting out, and if they haven't thought about it or really had a good experience there, they're not thinking of stopping, and they don't want something's blocking them from using. Okay. Okay. And then the other thing about buprenorphine, sorry, let me go back, sorry, that in terms of the pharmacopolicy, well, there was this X waiver, which made it very hard to deliver, and finally we've overcome that. I'm probably going on much too long, so I won't go too much into the story of X waiver, which is very interesting and kind of appalling when you think about the way in which the big pharma and politics played with delivery of a very safe drug. But suffice it to say that we've seen in the last year or so the end of the X waiver, so now makes it as a Schedule 3 freely prescribable to all kinds of people, and that it also has multiple delivery modalities, so that there are depot injectables, which are very, very useful in this population. Okay, so this is actually the graphic picture which I described. So again, sorry, I just always run ahead of my slides, but this is, if I had to say what's my favorite slide here, or maybe my favorite slide from a pharmacology talk ever, it would be this. Because here's the picture. So that buprenorphine's mechanism of action is, we see the red line is the effect of an agonist, heroin and others. And really it's leveling off, but it probably shouldn't, because the only way it really levels off is people are dead. If you could still take more, it would cause more suppression until people can't take it. Now, buprenorphine also has what's called the ceiling effect. So that when it is acting on the mu opioid receptor, if you add more, even though it has some positive effect, so get a little effect. So somebody who's never taken buprenorphine, could you get high? Maybe a little bit, but not too much. And besides, if you're not opiate naive, it will not have very much effect. But if you add more buprenorphine, it's not going to cause respiratory suppression. It's actually almost completely safe, and particularly in someone who is not opiate naive, who has upregulated receptors. It's impossible. Even though there were huge cautions over buprenorphine, it can cause, overdose death. It said, really, there's almost no good documented evidence for buprenorphine causing overdose death by itself. I mean, if you looked again, you say, what's the evidence in the evidence? If you looked at this, people had other things on board, other things were going on, environment, whatever. Many of the other things go on, but it's safe. It has the ceiling effect. So there is a limit to the respiratory and central nervous suppression that it can cause. As it also can have a limit to the euphoric effects. Okay, so what, again, maybe to give a little bit better picture for folks who might not know, is the what this means to have a partial agonist, partial antagonist. If you look at that little, there we go, that little receptor there. If you think of the best picture that I've ever come up with is the notion of a key in a lock, so that buprenorphine, so if the receptor is the lock, an agonist will fit in the lock and turn the key. But a partial agonist, partial antagonist fits in the lock but doesn't turn the key, or not very well, or it got stuck. So it does a couple of things. It actually blocks, and the other thing is, like a lock and a key, when it's sitting in the receptor, it blocks heroin, fentanyl, whatever, from coming in there. And it turns out that buprenorphine also, one of the other great features of it as a medication is it's more avid for the receptor than the positive agonist, and so it blocks them. And because it's more avid, it actually acts like Narcan. So I'm so sorry to go over. This is, I guess, what happens is I get talking. So Mario will be able to send on and post so people can read through, and I'd be happy to answer questions about some of the other topics. But I think the main messages here that I would like people to take away is that we have in New Mexico a problem which is disproportionate, like many of the state, is of the kind of burden that happens particularly in poor, rural, disadvantaged states, but that it also it turns out to be medically and socially complex. And so this is something which we have to deal with on many fronts at once. And as usual, the front line in medicine is primary care, and fortunately we can have a role, and I would encourage all of us, it's another theme altogether, but there is the, what we would say is under adoption of participation in efforts for treatment, and particularly now that we have the X waiver, we have less and less excuse in primary care for folks not to learn about it and treat it like any other condition that we might. So sorry to have gone over. I'll be eager to answer questions if people have them. Oh, just quickly, in case some of the medical people might not have seen, or providers, there's a new depot preparation coming out, which is better than Sublocade, which will really be great to add to the armamentarium. Then we had a little bit of scary stuff on xylazine and some polysubstance.
Dr. Leiderman, this is Kristen Drake with Peak. Thank you so much for your time and your expertise today. I really appreciate you. I have a quick question. Can you go back to the xylazine
Sure.
screen? Sure. Yeah, we just recently opened up an adolescent PHP and IOP clinic in Espanola, New Mexico, which, as we all know, does have a very high rate of opioid use disorder. And this is something that we've been hearing more about from the kids. And so I just kind of wanted to read through this, if that's okay, or if you can give us a quick blurb on it.
Yeah, sure. Yeah, or you're welcome to get in touch with me about it. So xylazine is pretty terrifying. And it's not something new. It was developed as a veterinary sedative. And the way it's appeared is for exactly that reason. So say, well, unfortunately, the unscrupulous people who are trying to keep in the business of distributing and making money off of people's misery, said, well, okay, how can we get people hooked? How can we have things last longer so that they really like it? How do we get things which are cheaper? How do we get things which are less regulated? There's this more pressure on the supply routes for chemical precursors, principally coming from China now, and then by way of Mexico, and dealing with it. What's a way around this? Well, this is a perfectly This is a perfectly legal medication. It just, you send it saying, I'm just sending it for veterinary purposes. And so, so I think that that's really how it's creeping in. And because, it was already there, it's cheap, you can synthesize part of a class of things which are already, well known in synthesis. That's how it's getting into the market. So what is it? It's a completely different mechanism. It's a alpha 2 adrenergic agonist. So it works. So again, makes it more awful. So the alpha 2 receptor actually is involved in another route of sedation. But because it's a completely different class, it actually doesn't have anything to do with the opioid receptors as such. It's a big problem because if somebody overdoses on xylazine, you can't reverse it with Narcan. It simply has nothing to do with Narcan. So and while there are alpha 2 receptor antagonists, they're not in common use because xylazine is not approved for human use, and they're mostly injectables now. People don't have a lot of experience with them. It's going to take research protocols to get them approved, so you probably have to see this in emergency rooms first. So it's terrifying. And then the other thing, which is easy to see from the pictures, say, well, this is not even well understood, but particularly for injection, it causes these terrible, terrible lesions for reasons which aren't entirely understood, probably because the alpha 2 adrenergic receptor is involved in vasoconstriction. So once you inject it, it sites distant from the injection site. You can have these terrible, terrible lesions, which is typical of the using. Now, as far as I know now, we haven't yet seen a lot of it in New Mexico, but that just means that for some of these innovations, it takes a while to get to us. It was the case with fentanyl, and it got here, in full force eventually. So are we probably going to see this? Yeah, but I would expect, well, I don't know what to say. I mean, I would personally expect that we won't see too many overdoses from it because it's not being used in a pure form. It's being used to cut mostly now, but probably, fentanyl, what happened with fentanyl? Well, fentanyl was cheap and undercut everything else. And so it became, by volume, massively successful for people distributing this stuff. So xylazine is likely to have the same fun, as I think about it, saying, yeah, xylazine will undercut fentanyl. And so, yes, it's going to be scary. Anyway, so not to keep people longer, but just say, if you want to get in touch with me about some of this other stuff, feel free.
For sure. Thank you.
Dr. Leiderman, thank you very much for joining us today.
Okay, thanks. Bye-bye.